All right, good morning, everyone. Thank you for the opportunity to present. I have no disclosures. So, iliac artery occlusive disease. When is treatment indicated? So, claudication, rest pain, tissue loss, embolic events, vasculogenic impotence, and improving inflow for concomitant procedures. Clues that the iliac artery may be involved when you're examining these patients, whether it be in the hospital or as an outpatient center. Leg claudication with a reduced femoral pulse. And then you can have symptoms and physical exam findings that hint at internal iliac artery involvement, including bilateral hip claudication, buttock atrophy, and erectile dysfunction. We've had excellent talks early this morning, so I won't go into the details about each of these. The workup can range as follows. A lot of these patients, particularly when they present with claudication, remember exercise APIs are helpful. Ultrasound is also helpful here. I included an ultrasound of one of my patients with iliac artery occlusive disease, and you see that tardus parvus waveform in the external iliac artery, hinting that there's more proximal inflow disease. Digital subtraction imaging, we also had excellent talks about that. Remember, multiple views. This is a 2D picture of a 3D problem. Furthermore, you can do pullback arterial pressures. This can help you, like, are these lesions hemodynamically significant? What numbers are we looking at? We're looking at a peak systolic to systolic pressure gradient of greater than 10 millimeters of mercury. You can also give epaverin or nitroglycerin to induce reactive hyperemia, and that hemodynamically significant gradient would be greater than 15% change. So, also excellent talks this morning. Optimal medical therapy is of utmost importance. A lot of the studies that we have are even before the application of some of these medical therapies. So I anticipate that their effect, particularly as we have better and better medical therapy, is essentially mandatory. So it's not to be overlooked. So patients who have claudication, I would argue that you should do your best to do non-operative management before. Optimal medical therapy, structured exercise, smoking cessation. These patients, the risk of limb loss is low for claudicants in particular, and everything we do has possible complications. So only when these non-invasive measures fail should you really consider revascularization. The other thing to think about is, particularly with our young patients, less than 50 years old, we know their outcomes in terms of interventions, whether it be endovascular, open, or poor. So if we can kind of support our patients along before intervening, I think that's also incredibly important. We have the task, different kind of grading of aortoiliac disease, from task A being the least extensive to task D being the most extensive. And traditionally, we've been taught that task A and task B lesions are more amenable to endovascular approach. And as you go in more extensive lesions, open revascularization is more recommended. So, in general, when do we really need to consider open reconstruction, particularly when the aorta is involved in the iliacs? So if there's extensive long segment occlusive disease, it's something that you have to kind of bear in mind, say, hey, maybe this person needs to be an open candidate, or potentially aortic occlusion immediately distilled into the renal arteries, right? So if you're trying to get into the intraluminal space around the area of the renals, you have to realize that there are complications in terms of perforation, dissection. So that's something that potentially an open operation might be better suited for. Patients' perioperative risks, we have to take into account the entirety of the patient, right? What are their comorbidities? What are their limitations? What's their life expectancy? We had this hinted at our previous talk. You know, somebody who's more bound, maybe not either, exhausting and doing an amputation is something to consider versus, just conservative therapy. We have multiple risk stratification and prediction models. They take into account multiple criteria, and they can help us in terms of better risk stratifying our patients. Patients that have high risk, so patients who have severe cardiopulmonary disease, who have a hostile abdomen, who have a history of intra-abdominal infections. These are patients that are probably better suited for endo versus open. Now we have to talk about patency. So our gold standard, our aortobifemoral bypass, has long historical data of being, has a long and a high patency rate, upwards of 10 years. This drops off as you go to the femoral bypass and the axillobifemoral bypass. And the patency of the unilateral axillofemoral bypass is also significantly worse than the bilateral, the axillobifemoral bypass. So this is something to take into account. So for example, patients who have heavily calcified iliac disease or have occlusions, there's also been a trend to do some more hybrid approaches, and I'll touch on that momentarily. Task A and Task B lesions, so the primary patency is a little bit lower, 10 years, 71%. But as we're getting more and more information, we're realizing that their secondary patency is quite good. And this is slowly starting to trend into the Task C and D lesions as well. Complications of open surgery, while it is oftentimes the treatment of choice for patients who have extensive iliac disease, there's a mortality, a 2.4 to 4% mortality of open reconstruction with a significant perioperative morbidity of about 20%. So that's something to think about with these patients. We're also now doing hybrid endovascular open repair. So it's incredibly important when you're examining these patients, don't forget about the common femoral artery and the profunda femoris, right? So if you are doing extensive iliac work endovascularly, but the common femoral artery is occluded, these patients aren't going to see a lot of that benefit. So oftentimes we'll do a femoral endarterectomy with retrograde iliac stenting. When you take these patients to the OR, you will likely try to traverse these iliac lesions before you proceed with an endarterectomy. That way you don't essentially waste your time. And their patency is quite excellent. This is a patient of mine. I included an image of exactly that. So what is technical success when in the endovascular realm, right? So less than 20 to 30% residual stenosis without dissection, perforation, occlusion, a systolic pressure gradient of less than 10. Focal lesions, Task A and Task B, have been treated with angioplasty and stenting. Task C and D lesions, we've had the COBEST trial that demonstrated that stent grafts are superior compared to bare metal stents in long-term patency and clinical outcomes. Location matters, and this is Dr. Hahn kind of alluded to. So common iliac artery, if you're treating someone who has a lesion in the common iliac artery, oftentimes you'll do ipsilateral access for the site of the intervention. You'll preferably use balloon expandable stents in this location due to their precise deployment and radial strength. The external iliac artery, oftentimes we'll use contralateral access for the area of the sheath site of intervention. Self-expanding stents are excellent in this area, specifically due to their flexibility and conformability. The distal aorta, you'll do bilateral balloon expandable stents, oftentimes to avoid any damage to the contralateral side. Sizing, 5 to 10% of the adjacent vessel or the contralateral vessel you can use to help facilitate that. Remember, heavily calcified vessels, you have a risk of rupture, and the intravascular ultrasound, as was alluded to earlier. In terms of angioplasty for type A and Task A and B lesions, so you look at the 4-year success, you're looking at 44 to 65% just with angioplasty alone. And they have complications, particularly distal embolization. So you have to keep that in mind. There's been multiple studies in the past, including the Dutch iliac stent trial, that compared balloon expandable stent as their primary treatment versus angioplasty and then selective stenting. And they found no statistically significant difference. But if you look, 43% of the patients who are angioplastied were then stented. So it's a very heterogeneous group, and the complications were more in the angioplasty group. Predictors of failure, the more severe your disease, the more likely you're going to have a decreased patency. So claudicants, you see here, and then that decreases as you move on to critical limb ischemia. Increased 10-year patency for Task A and Task B lesions, or if you have a presence of two-vessel femoral runoff, tibial patency, and both ideally. Other predictors of failure are extension into the external iliac arteries, female gender, and small vessel size. Endovascular interventions of the iliac vessels in particular are not without complications, whether it be access, arterial rupture, which Dr. Rao will comment on briefly in the brief future, arterial dissection, and embolization. Most important thing is to plan and to be prepared. And then surveillance, ABIs, optimal medical therapy, and we kind of commented about the changing of the antiplatelet and dual antiplatelet. Thank you.